is hyperthyroidism. Okay, so it's not a very significant cause of hypertension. It mainly causes systolic hypertension. So, you can mention it, but please don't mention it as the first cause of secondary hypertension. Okay. The first cause we have just, the most prevalent causes, of course, would be your renal causes, okay, and renovascular. And now, when should we suspect secondary hypertension? Okay, when someone has severe hypertension, especially if the systolic is higher than 180 or the diastolic is more than 110. Then the next scenario would be resistant hypertension, okay? So, resistant or medically refractory hypertension, okay? Now, this is the definition of medically refractory hypertension, and I expect you to know this. The patient should be on at least 3 classes or more of antihypertensives, including a diuretic at an adequate dose, okay? And the third scenario would be an acute rise or, sudden onset of labile hypertension in a previously stable patient, patients with malignant or accelerated hypertension with end organ damage, young hypertension, which is defined as age less than 30 years. But there's a caveat here. They need to be non-obese with no family history, okay? Because we do see with the rising prevalence of obesity, you see a lot of obese patients, metabolic syndrome and hypertension, okay? So it would be, more likely to be secondary hypertension if the person was non-obese. And then if the patient manifests with classic syndromes, hypertension with the classic Cushingoid, features, okay? Hypertension with electrolyte abnormality. The key electrolyte abnormality would be hypokalemia with metabolic alkalosis. So this is a common scenario. Yeah. So maybe we can make it a bit interactive, although that would make the session a bit longer. But I only know I can't see who else is here when I'm in presentation mode, but I do know Krinath is here. So Krinath, can you list the causes of hypertension with hypokalemia and metabolic alkalosis?
Con syndrome.
Okay. Yeah, okay. It's better to say primary hyperaldosteronism, which could be due to Con syndrome, which is an adenoma, or bilateral adrenal hyperplasia. Okay, what else?
Cushing syndrome.
Okay, yeah. What else? Anything else? I think there are at least 3 other causes, Krinath. The main ones I expect you to know. Good, okay. I'm not sure who that is, but good. What else?
Liddle syndrome.
Yes, good. One more. I'm not confining myself to endocrine causes. If it's a non-endocrine cause also, it's okay. One more main one. Renal artery. Yes, correct, yeah. So all these will present with hypokalemia and metabolic alkalosis, okay? So, and Liddle's, as you know, we won't be talking about it, but Liddle's is basically abnormality, inherited abnormality in this, a mutation in the sodium channel, where the patient will appear to, have features consistent with Con syndrome, but when you actually measure the aldosterone and renin, okay, both the aldosterone and renin are low. Okay, so these are the main differential diagnoses that I expect you to know. Okay, and of course, if you have somebody with hypertension and also has an adrenal tumor, okay, incidentally picked up on a CT scan, then you also need to suspect these endocrine and secondary causes. The key a summary of the key features of these endocrine causes. Now, primary hyperaldosteronism, the majority of patients are actually fairly asymptomatic in terms of their hypertension. Quite similar to essential hypertension in that sense. And although it is a cause of hypokalemia and metabolic alkalosis, in the early stages, more than 70% are actually normalkalemic. Okay, so just because somebody has normal potassium doesn't mean that you should dismiss the possibility of hyperaldosteronism. Okay, of course, you need to suspect it if a patient has unexplained hypokalemia, is not on diuretics, etc. Okay, and in the later stages, they may actually have episodes of paralysis. Okay. Now, Cushing syndrome, of course, the classical picture is rapid unexplained weight gain, hirsutism, amenorrhea, infertility. They will have a Cushingite body habitus, and the classic features which we'll go through later. Okay. And Pheochromocytoma, of course, classic triad, which is paroxysmal, of funny spells. Okay. And the three classic features would be headache, palpitations, and sweating. Okay. Now, what is more like this is another thing that a lot of MOs, when I ask them, like, one of the early, one of the first things they will reply when you ask them what are the features of pheochromocytoma is that they will say that patient has flushing. Okay, rarely you can have flushing, but what is more common is pallor. Okay, because you can imagine if you have a huge load of catecholamines rushing into the bloodstream, what do catecholamines do? Mainly it is vasoconstriction. So if you vasoconstrict, you will become pale. But there, of course, there will be a small percentage of people who also have flushing, so it is mentioned as a feature, but more common would be pallor. Okay, and of course, these patients may have labile blood pressure, and there is a significant postural drop in blood pressure as well. And another typical presentation is that there is exacerbation of high blood pressure in response to certain drugs which precipitate catecholamine release. Okay, there are certain anesthetic agents, okay, succinylmetonium, etc., okay, which can precipitate a crisis. Okay, the stress of surgery, drugs like opioids also can, or metoclopramide, are known to, also precipitate pheochromocytoma crisis. So a very classic referral would be, somebody went for surgery, and the moment they were induced, then there was a jump in the blood pressure. So you need to consider that pheochromocytoma in those situations as well. Okay, and of course, if it is a familial form, okay, there will be the other features when there's a family history of young hypertension, there'll be all those other features of those syndromes. Okay. The multiple endocrine neoplasia type 2 syndrome, von Hippel-Lindau syndrome, neurofibromatosis type 1, we do expect you to know a little bit about all these syndromes as well. So in von Hippel-Lindau, for example, if you have cerebellar hemangioblastoma, or sometimes even hemangioblastoma in the spinal cord, sometimes associated with renal cell carcinoma as well, and the patient is young and has hypertension also, okay, and all these features that are suggestive of VHL, you also need to look for pheochromocytoma as well, and also neurofibromatosis type 1, where you have all those the classic neurofibromas, okay. You also need to, and cafe-au-lait spots, you also need to think about screening for pheochromocytoma. Okay, so now we'll start by talking about the most common adrenal cause of an endocrine cause of hypertension, which is primary hyperaldosteronism. So this is the historical view of primary hyperaldosteronism. Okay, so in the early days, when it was first described by Jerome Kohn, okay, the initial case was adenoma, and therefore Kohn syndrome refers to adenoma, and it was thought to be rare, occurring in less than 1% of all patients with hypertension, okay? But fast forward to modern times, okay, because more and more people are being screened for primary hyperaldosteronism. We know that it's actually the commonest curable form of secondary hypertension. It can account for, up to 5 to 25% of cases of hypertension, depending on the type of population you are evaluating. So if you're just evaluating, a general population of hypertensives, okay, it might be a lower percentage, 5%, okay, of patients who present, for example, to primary care. But if you think of those patients being managed in specialist clinics, which would be slightly more refractory, maybe it might be 10%. And when you narrow down the population to those with resistant hypertension, up to 1/4 of patients might have primary hyperaldosteronism. As I mentioned earlier, only about 9 to 37% will be hypokalemic. Okay, and these patients, why is it important to detect them? What does it matter? If you just treat them with antihypertensives, won't you reduce their cardiovascular risk and risk of complications? No, that's not true. If you compare patients, a patient with hyperaldosteronism and somebody with essential hypertension, even though they have the same blood pressure, the one with hyperaldosteronism will have higher cardiovascular risk because the hormone itself, results in cardiomyopathy and greater prevalence of renal complications, etc. Okay, there's a toxicity to the hormone above and beyond the actual level of blood pressure. Okay, so historically, they only knew about the adenoma. That's why it was called Conn's adenoma. But what we now know is that bilateral adrenal hyperplasia is far more common than a unilateral aldosterone producing adenoma. So when I ask you, adrenal causes of hypertension, you should say primary hyperaldosteronism, and the majority of those would be due to bilateral gland involvement, and it would be hyperplasia, and only about slightly more than 1/4 would be due to a unilateral adenoma. Okay, now there is a rarer form, okay, which we won't spend much time on. Okay, a rarer form of hyperaldosteronism known as glucocorticoid remediable hyperaldosteronism, or GRA. This is a inherited form, okay, because of a genetic mutation where it is ACTH levels that are actually driving aldosterone synthesis, okay? Whereas in a normal person, the RAS system, the ACTH doesn't play a large role. ACTH just plays a role in cortisol secretion, okay? So therefore, in this inherited form, which is pretty rare, so usually, you can exclude it usually based on history. So if somebody with a young hypertension has a strong family history of young stroke, okay, then you need to think about this glucocorticoid remedial hyperaldosteronism. And this is also a condition because it's a genetic mutation, both adrenal glands are involved. So you don't do surgery for this condition. So usually the treatment is with dexamethasone. So you give us low dose of dexamethasone to suppress the ACTH, then the ACTH will no longer drive aldosterone secretion, okay? So it's a very rare form of familial hyperaldosteronism. And if you do suspect it, you just send for genetic testing, okay? But most of the time, you don't need to consider it, but just be aware of it, okay? Okay, so remember, when I started off, I said that, okay, secondary hypertension, they're kind of rare, so you can think of them as zebras, okay? But I've just shown you and demonstrated that, actually the reality is that in modern times, it's not really rare. It can be up to 1/4 of the of particular populations, especially those with resistant hypertension. So it's actually a horse disguised as a zebra. Okay, let's move on to the evaluation of somebody in whom you suspect has primary hyperaldosteronism. Okay, so this is what you really need to know about. Okay, there's a 3-step process. Okay, so if you suspect it, first you screen the patient, and you screen with aldosterone-renin ratio. Then if the aldosterone to renin ratio is elevated, the next step is confirmation that secretion of aldosterone is actually autonomous. Okay, it's not controlled by negative feedback, and it's non-suppressible. Okay, and you do that usually the well-known test is a saline suppression test. Okay, but there are newer tests such as the fluorocortisone suppression test. Some centers practice that as well. Okay, and there are several other tests that we will discuss in the upcoming slides. Okay, and once you have confirmed that there is autonomous secretion, then you need to determine, okay, is it unilateral secretion or is it bilateral secretion due to hyperplasia? So that's known as subtyping. Okay, because the management is very different. If it's unilateral, then treatment is surgical. Okay, if it's bilateral, treatment is medical. Okay, with a mineralocorticoid antagonist. Okay, so let's go to step 1 first. Okay, so if you measure the aldosterone and renin, okay, in a classic presentation, the serum aldosterone is high in the presence of a low renin. Okay, so usually, if it is a patient with primary hyperaldosteronism, the serum aldosterone will be more than 15 nanogram per deciliter. Okay, although the guidelines actually don't really give you. Although they say it frequently is more than 15 nanogram per deciliter, you don't need to fulfill that for the patient to have cons. Okay, the important thing is that the ARR is raised and in the presence of a low renin, but most of the time the aldosterone also will be more than 15 nanogram per deciliter. Okay, there are other units. Okay, but what I have memorized are the nano units using various web calculators. Okay, so now how you collect the ARR specimens for your ARR is very important. Okay, so the minimum requirement would be that you need to collect the blood mid-morning after the patient has been up, for at least 2 hours, and seated for at least 5 to 15 minutes. When we say up, we don't mean that patient has been standing for 2 hours. Okay, as long as they are not supine, that's fine. Okay, and you take blood while the patient is seated for at least 5 to 15 minutes. Okay, and the patient should have been on a normal sodium diet. Okay, you don't want them to have been on a sodium restricted diet because that can lead to elevation of renin and can cause a false negative ARR. Okay, and you also, of course, need to make sure that the potassium is at least 4.0. Okay, and that is because hypokalemia of itself can falsely lower the aldosterone, and again, that will result in a false negative. So these are the minimum requirements which you may be tested on in the SBAs. Okay, so these are the 3 most important requirements. And then you also need to withdraw drugs that markedly affect the RAS for at least 4 weeks. The most important agents that you need to make sure the patient is not on would be any kind of diuretic, either whether it is a potassium sparing diuretic or a potassium wasting diuretic. The potassium sparing ones will increase renin, and so will the potassium wasting ones. And licorice products also can affect the RAS. Okay, ideally you would you would want, since these patients have hypertension and sometimes it may be medically refractory. Ideally, you would want patients to be on medications that do not affect the aldosterone and renin levels at all. And it would be these 3 classes: verapamil, hydralazine, and any alpha-1, peripheral blocker. Okay, but practically speaking, this is not always possible. Okay, so you need to be aware of this. These patients already have medically refractory hypertension. And we know that, the easiest drug to start for blood pressure control would be amlodipine. Invariably, these patients would be on amlodipine. They might be on some beta blockers. They would be on ACE inhibitors or ARBs as well, there are some, so it's a bit controversial, so there might be some centers, okay, like I don't know whether UKM is still like that, okay. So some endocrinologists, they are really purists, They will not measure the ARR unless they have changed all the medication to something from these three classes, okay. But you do, whereas there are other endocrinologists where the main thing is we are concerned with, like, say patient is on like 3 or 4 drugs, and all of them kind of affect the RAS, but then they don't come from, they are not diuretics, okay, so they don't have a major effect on the RAS, okay. Now if you were to suddenly switch all these drugs in somebody who has poorly controlled hypertension to these agents, which are not very potent in some cases and require a lot of titration, you run the risk that during that transition period, you lose control of the blood pressure, and the patient may get a complication. I have had the misfortune of, when I worked in a different center, and the consultant asked us to switch over, where the patient, unfortunately, during the transition process, actually was admitted with a stroke. Okay, so you don't, there's always that risk. Okay. You may be lucky and some patients may get away with it, but most endocrinologists these days, as long as you're not on a diuretic, and you fulfill those other conditions, normal sodium diet, potassium is more than 4, okay, evaluating the ARR is still possible, okay, because you can interpret, the ARR even if the patient is on these confounding agents, okay. So, for example, so usually if the patient is on, a drug that affects the ARR value, but yet the ARR is high, okay, you can still accept it, because the general impression is that as long as you're not on a diuretic, okay, these drugs do not give a false positive. So you have primary hyperaldosteronism. But if the patients are on these drugs and the ARR is negative, and you still strongly suspect primary hyperaldosteronism, yeah, then that is possible that it is a false negative. Okay. So, for example, if a patient is on an ACE inhibitor, okay, or ARB, okay, so you need to know your renin-angiotensin system physiology. If somebody is on ACE inhibitor, what happens is that it inhibits conversion of angiotensin 1 to angiotensin 2, and therefore, there will be an increase in the renin level, okay? And that will be upstream. Upstream, there will be a compensatory increase in the renin level. Downstream, there will be reduction in aldosterone levels, okay? So knowing this, okay, say somebody is on an ACE inhibitor, and then you measure the aldosterone, but the aldosterone is super high, then all the more, you're convinced that this is primary hyperaldosteronism, because like in a normal person, if you put them on an ACE inhibitor, the aldosterone will be low. But here the patient's on the ACE inhibitor, but aldosterone is very high and the renin is very low. Okay, so you can take that as being suggestive of primary hyperaldosteronism, and you do not need to retest the patient after stopping the drug. Okay. However, if patients on ACE inhibitor and the aldosterone is not elevated and renin is suppressed, then that it is a possibility that it's a false negative. Then you just stop the drug for 2 weeks and repeat the test. Okay. And the rest of the table also explains that, and illustrates that fact that only diuretics are the ones that you need to be wary of, because they can give you stronger likelihood of having a false negative. And these drugs you need to stop for a minimum of 4 weeks. Okay? So now, once you have done your ARR and you find it is elevated, okay, then step 2 is confirmatory testing to show that it is non-suppressible. Okay, so in our center, what we usually do is the saline suppression test. You infuse 4 pints or 2 liters of normal saline over 4 hours, and then the renin and aldosterone and it will give someone what is the volume of I mean, it doesn't stop reabsorption. It causes a reabsorption of sodium. So if you give a large volume of saline, then by right, in normal person, the aldosterone should be suppressed because there is already a lot of sodium in the circulation. So why is aldosterone needed to reabsorb sodium? Okay, so it should fall to less than 5 nanogram per deciliter. Okay, and in that case, then primary aldosteronism is unlikely. However, if the aldosterone is more than 10 nanogram per deciliter, then it's very probable, this is non-suppressible, it's very probable the person has primary hyperaldosteronism, but you don't know whether it's unilateral or bilateral. Other methods of testing would be oral sodium loading test. So it's all different versions of increasing salt levels, okay? Or the fludrocortisone suppression test, okay? Fludrocortisone causes, is a mineralocorticoid and causes retention of sodium. But actually the most sensitive test is actually the fludrocortisone suppression test, okay? Fludrocortisone, if the aldosterone level is more than 6 nanogram per deciliter, that confirms primary hyperaldosteronism. Okay, so okay, now after you have confirmed that it is non-suppressible, then you go on to do your CT scan of the adrenal. So it must be you can't ask for CT abdomen, because the cuts must be very fine, okay, and thin slices, and you need to specifically order 3-phase CT adrenal. And another important rule in endocrinology is that imaging always comes after biochemical confirmation. Okay, you have to work up the patient step by step, because what we are worried about is incidentaloma. Okay, and especially as the patient gets older, okay, there will be some, you image the person, any organ in the body, there will be some lump and bump somewhere that is pathological. Same goes for the pituitary gland, other organs, you often find like non-significant thyroid nodules, okay? So you always do the imaging after biochemical confirmation, okay? And this is what, so you might be given these questions in the OSCE, okay? Data interpretation of scans, okay? This is what a normal scan looks like, okay? This is a crucial feature because you need to look at the crura of the diaphragm, okay? So this is the crura of the diaphragm over here. And you look for the adrenals above the kidneys, usually it'll be tri-leaflet in shape, okay? And this is a healthy adrenal gland, okay? The limbs of the adrenal gland, okay, should not be thicker than the crura of the diaphragm. And you can see here that it's very similar, okay, the thickness of the limbs of the adrenal gland, okay? But however, over here, you can clearly see that, there is an adenoma over here, okay? And the classical appearance of whereas this is the normal adrenal gland on this side, okay? Now, the classical appearance of a Cons adenoma would be hypodense, okay? Both on the plane film and with contrast, it will not take up much contrast. And you see that this is a contrasted film, okay? The aorta is bright over here, but you can see that the tumor over here does not take up contrast, okay? So this is the classic. So after your CT, okay, so you've done your ARR for case detection, you've done your saline suppression test or fluorocortisone suppression test or confirmatory testing, done your adrenal CT, okay? Now the next step, okay, would be to determine whether it is unilateral or bilateral. Now, even if on your CT scan you see unilateral lesion, that most of the time, especially if the patient is older, does not indicate that that is the culprit lesion. And I'll go through that, why that is so in a while. So it's, except in rare circumstances, okay, the next step after adrenal CT is not to go straight to surgery, but it is to, if indicated, but it is to do adrenal vein sampling. Okay. Now there will be some patients who will tell you that at the outset that they are, whatever the result, they don't want surgery. Okay. Now, because adrenal vein sampling is something where you need a very highly skilled radiologist, okay, and you need to send them to a center that is experienced with it, and that that it is, although it's quite rare, it is a kind of an invasive procedure. You don't want to unnecessarily do adrenal vein sampling in somebody who, like, from the outset, he's telling you, he's not going to go for surgery, and if he's not going to go for surgery, you have to treat him medically anyway. Okay, so there is no, so you must have that discussion with the patient lah. You must explain that, I can't tell at this stage, is it bilateral or unilateral, and what your appropriate management should be, medical or surgical. We need to do adrenal vein sampling, and if it shows unilateral secretion, you need to go for surgery. Now, would you be willing to go for surgery? If patient says no, you just don't do the adrenal vein sampling, you just treat them. Now, why is adrenal vein sampling necessary? Okay. Now, that is because there may still be bilateral hypersecretion of aldosterone due to bilateral hyperplasia, regardless of the CT scan appearance. Okay. The presence of a nodule on CT does not correlate with aldosterone secretion. Okay. So presence or absence. Okay. So if the CT scan looks completely normal, okay, it may be that the tumor is too small to be seen. Okay, there may be a unilateral small lesion. Okay, or if you do have a lesion but it's not very large, okay, this could be an incidentaloma, especially if the patient is above the age of 35. Okay, if less than 1 centimeter, you still need to go ahead with ABS. Or you could see bilateral nodules, in both adrenals, but the one that is hypersecreting might just be on one side. It doesn't mean just because both sides are nodular that it's bilateral adrenal hyperplasia. Okay. So there is one exception though. Okay, sometimes ABS may not be required if the patient is young, less than 35, and there's a classic CT phenotype and a very large lesion, more than 1 centimeter, is hypodense and looks lipid rich. Okay, and aldosterone is very high and the renin is very low. Is very non-suppressible. Then sometimes you can make an exception and skip the ABS and go straight to surgery. Okay, but that is unusual. Okay, now what is the principle of adrenal vein sampling? Okay, so basically what you're trying to do is that you're trying to evaluate the aldosterone levels in the adrenal veins that are draining the adrenal glands. Now, if you have, the aldosterone level on one side, okay, if in this image on the right side is markedly elevated and compared to the left side, okay, that usually indicates aldosterone producing adenoma. It's elevated, that indicates hyperplasia. Now, it's not just that one side is higher than the other side. The one side is very high and the other side is actually suppressed. It's actually, lower the aldosterone value in on the other side, okay, will be lower than that in the IVC or the peripheral circulation, because when there's hypersecretion on this side, it will suppress the other side. Okay, so that is the basic principle. So if you find one side is elevated, then you go for surgery. Both sides are elevated, medical treatment with either spironolactone, such as eplerenone or finerenone. Okay, so okay, that is just a very rough approximation of the principle. Okay, now if you're I think if you're going for the MRCP, most probably they expect you just to know up to that level. But unfortunately, at the master's level, which I feel is like a little bit unfair, but this has been a past year question in the past. They actually expect you adrenal vein sampling. So you need to know a little bit more detail about that, okay, how to interpret it, because we don't just measure the aldosterone level, we also measure the cortisol level, and the procedure is also done under ACTH infusion. Okay, so throughout the adrenal vein sampling procedure, the results of the AVS, if there is an adenoma, the infusion of ACTH will exaggerate the difference between the two sites in aldosterone secretion. So we do send patients for AVS under ACTH stimulation. Okay, so going back to this slide. Okay, now why is it sometimes difficult, quite often difficult to do adrenal vein sampling? Okay, usually the problem is that the right adrenal vein is more difficult to cannulate compared to the left adrenal vein. Okay, so the right adrenal vein drains directly into the IVC, but it's like more narrow, and the angle at which it enters the IVC is more difficult to cannulate. Okay, so basically your radiologist will cannulate the femoral veins bilaterally, and then they push the catheter up there, and then they try to position the catheter in the right adrenal vein and in the left adrenal vein. And the right side is usually a problem. Okay, so now this procedure, it sounds simple in theory, but it's actually very difficult, because basically what the radiologist is doing, like they inject some contrast, and then briefly you have an image, you kind of know where you are, and you advance, and then you get into the adrenal vein, and then you might get there, but then like the catheter may slip out. You may think you're there, you inject a bit of contrast, the anatomy looks okay, you're in there, but 3 minutes later you may have slipped out. So how do you make sure that that the catheter is really inside too? Okay, so you also have to simultaneously, besides measuring aldosterone, we also measure cortisol. Okay, because the cortisol level, okay, in the adrenal vein closer to the adrenal gland, if you are actually in the adrenal vein, will be at least 5 times higher than the sample in the peripheral vein. So if your cortisol is more than 5 times the peripheral vein cortisol value, then you're inside too. You're in the adrenal vein. And this is what you need to understand in order to interpret the AVS. Okay, so first of all, you need to determine the selectivity index. Results come back. Now, in some centers, they do have a rapid cortisol assay where there and then the radiologist knows they are in, because the cortisol level is more than 5 times, the periphery. Okay, but the kit is quite expensive, so unfortunately we do not have it available in most hospitals in Malaysia. Okay, so most of the time you send the patient for adrenal vein sampling, and then only when the results come, unfortunately there have been many occasions the results come back and then you that in the periphery and actually, you know, the AVS was not successful, okay? And then you have to, so when you counsel the patient with AVS, you need to tell them it's not an easy procedure, but it's very important we do it, we need to try it, okay? So there are some special scans that you can do which are not available in Malaysia, you know, some special nuclear scans such as the metomidate scan, which enable you to bypass the step, but it's not available in Malaysia. And I think maybe it's only just becoming available in some private centers in Singapore. Okay, so for now, everybody has to go through adrenal vein sampling. Okay, so now most centers we do the adrenal vein sampling with co-syntropin lah, okay, which is your synectin. Okay, so the selectivity index without co-syntropin is different compared to with co-syntropin. I think nearly all proper endocrine centers use co-syntropin. So just remember this lah. The central value the ratio needs to be 5 centrally compared to 1 peripherally lah. 5 times higher than the periphery. Then you look at the next thing you need to look at is that you can, if the AVS is successful, you can look at, go straight to the lateralization index. Okay, so the lateralization index, the aldosterone needs to be corrected for the cortisol value. So you divide the aldosterone by the cortisol, okay, on both the right and the left, and then the ratio of one to the other. Okay, if there is a unilateral lesion, okay, with co-syntropin, okay, then the aldosterone to cortisol ratio on the site of the adenoma should be more than 4 times that on the contralateral side. Okay, if the ratio is less than 3, that indicates bilateral. More than 4, it indicates unilateral. But as I told you, most of the time, the radiologists, you know, except in very experienced centers like Putrajaya, they will fail to cannulate the right side. So in that case, there is a third index which may be useful, especially if the lesion is on the right side. Say the lesion is on the right side, and then the radiologist fail to cannulate the right side. Then usually they will be able to cannulate the left. Then if on the left side, it is suppressed, the aldosterone to cortisol ratio is, lower, the contralateral aldosterone to cortisol ratio is lower than the peripheral ratio, indicating that it's suppressed on that side. That is also strong evidence that although they fail to cannulate the right side, most likely the lesion is on the right side. Okay, so this is an example of AVS. Okay, so yeah, the question came out once, but subsequently I think it did not come a few years ago in an MEQ, but so it was not like the whole, MEQ, there are several parts, so if you don't get this section right, I mean, you would have got some marks in the earlier sections lah, okay, so so you just need to remember the main principles, okay. And so basically they give you a chart of readings, okay, at 4 time points. Usually it'll be like 5, 10, 15 minutes, or maybe just 1 time point, okay. And they'll give you the peripheral. In the peripheral vein, you would have measured the aldosterone and cortisol, and then you can see the ratio over here is 1.61. You divide the aldosterone here by the cortisol here, and you need to correct all the values for the cortisol. It's 1.61, okay. And actually so that is the peripheral value. But the first thing you need to do is you need to know whether the catheter was in situ. So first thing you zoom in on is the cortisol in centrally here on the left and the right. And then you see, is this cortisol compared to the periphery cortisol, is it 5 times or higher than the periphery? This clearly, this is 30,000, this is 1,400. These are the typical ratios we get in kind of values we see in AVS, okay? So this is clearly in situ, Okay, then this one also is in situ. Okay, and you can see that on the left side, everything is in situ. On the right side, at like the first time point of sampling is usually 5 minutes, it was in situ. 10 minutes, it was in situ. But by the later part of the AVS, it has slipped out. It's no longer 5 times the periphery cortisol. So you can see, how difficult it is. But luckily, like at least there are some samples that were in situ. So now you can interpret it. Okay. So then you again you divide the aldo by the cortisol, divide the aldo by the cortisol here. That these are the ratios. Okay. Okay. Now you want to see whether it lateralizes. Okay, both sides are in situ at these 2 time points. Okay, so you divide 7.6 by 1.06. You divide 24.7 by 1.03. I mean, it's very clear lah. It's more than 4, right? So this one is lateralizing to the right. Okay, so this is pretty straightforward. Okay, so yeah, this is an example of AVS. So this is the algorithm, what you should do. Okay. For the most part, you need to know about this. Okay, there are some exceptions, where you can even skip the confirmatory testing, or you can skip the AVS, which I briefly mentioned to you. But I think at your level, they probably don't expect you to know these exceptions. You just need to know these major steps. Okay, so now let's move on to Cushing syndrome. Okay, but maybe before I go on, any questions? I think maybe you can save them for the
Hi,
end.
Prof.
Okay, if there are any questions. Okay, let's move on to Cushing syndrome. So this is yes, yeah. Who is that? You want to ask me something?
Oh yeah, hi Prof. I'm Boon here. I just want to ask, during AVS sampling, sometimes when the patient have allergic reaction to, like for say contrast, then they might give some corticosteroids to suppress the allergic reaction. But
Yeah,
will it affect the cortisol result?
yeah. Yeah, it will affect it, but then like you would expect it to affect both the right and left adrenal similarly. So you still can interpret it lah. All the values will be equally if affected lah. So it's still, since you're working with ratios here, it should be okay.
I see. Okay.
We have occasionally had those patients. Yeah. Okay. So okay, Cushing syndrome, this I expect you to know. Okay. Although there's like a whole constellation of signs that are associated with Cushing syndrome, the classic one would be moon phase, dorsal cervical hump, etc. Okay, but not all these signs are very discriminatory. Okay, so there are 5 major discriminatory features of Cushing syndrome. Okay, and you will notice that moon phase, buffalo hump, all that are not there. Okay, so the most discriminatory would be what I put in asterisks here. Okay, proximal myopathy. Okay, and this triad of dermatological features. Okay, abdominal striae, okay, thin skin, and easy bruising. Okay, because high cortisol levels impair collagen strength. Okay, and the abdominal striae are not just any abdominal striae. They need to be quite red and purple, and they need to be broad, more than 1 centimeter in width. Okay, because many people have stretch marks and striae alba, etc. Okay, and some patients also may even have like reddish stretch marks, but they're very narrow. No, they should be more than 1 centimeter. Okay, they should be very classic. And also the presence of young osteoporosis, young hypertension, also very classic. And facial plethora also is quite discriminatory. So like moon phase, buffalo hump, all those, like, you notice some of your metabolic syndrome patients also have a round face, so it's not very classical. Okay, so these are the most discriminatory. So the subtypes of Cushing syndrome, okay, the most common cause of Cushing syndrome is actually exogenous Cushing's or iatrogenic. Okay, Then subclassification of endogenous Cushing's, which is what we are concerned with here, okay? You subdivide them into ACTH dependent and ACTH independent. So the majority of cases would be ACTH dependent in adults, okay? Whereas ACTH independent is less frequent. That only accounts for about 20% in amongst adults, okay? And so when it is ACTH dependent, so by definition, then the ACTH it may be either normal or high, okay? If it's ACTH independent, the ACTH is suppressed, okay? So ACTH dependent, the most common form is actually pituitary origin, okay? You have a pituitary adenoma. This accounts for about 70% out of that 80% lah, ectopic ACTH is actually the rarest form of endogenous Cushing's, okay? Your ACTH independent would be your adrenal tumors, okay? More commonly it's an adenoma, rarely it's a carcinoma. These are rarer forms of ACTH independent where you have like, this one is for endocrinologist level, bilateral nodular enlargement, either micro or macro nodular. This is very uncommon. So for you just need to know about the first four, okay? Yeah, so even before you go on to your ACTH measurement, say you have somebody with clinical features of Cushing syndrome that are quite discriminatory, the history is typical, rapid weight gain, some amenorrhea, and then a patient has proximal myopathy and, has those dermatological manifestations. Even before you go on to measurement of ACTH or doing the test, you can have some clue as to which subtype it is, okay? So that sometimes can be quite useful, okay? So pituitary origin Cushing's is usually quite mild, okay? Patients will not look floridly Cushingoid. Whereas those with ectopic ACTH is usually very severe. Okay, it's usually very severe. Patients will look floridly Cushingoid. And adrenal adenoma is between the two lah. It's not mild disease, okay, but it's not very severe disease either. Okay, and another differentiating feature would be that in ectopic ACTH, not only are they very floridly Cushingoid, there's because the ACTH is very high, okay, there may be some element of hyperpigmentation because, as you know, ACTH is similar in structure to melanocortin, MSH, okay, which is responsible for pigmentation, okay. And there are very severe electrolyte abnormalities. Although all forms of Cushing's, you may have some hypokalemia and metabolic alkalosis, it will be more severe in ectopic ACTH. Electrolyte abnormalities are more prominent, okay? And another differentiating feature is that with adrenal carcinoma, in a female, the testosterone will be very high, and so will the DHEA. And so forth, hirsutism and virilization might be a prominent feature with carcinoma. So these are some clinical clues that will already help you to determine the subtype even before you do any tests, okay? So in Cushing's disease, the ACTH might be in the normal, upper half of the normal range or slightly elevated. And you usually have very mild disease, female preponderance. Again, important to note, okay? Majority are microadenomas. So, very often, it may not even be visible on MRI of the pituitary gland. 50% of cases with Cushing's disease due to a pituitary tumor, okay, the MRI might be even normal, okay? And certainly, they're not going to have any visual field defects because only about 5% of them are macroadenomas. If they do have a macroadenoma, if you have a macroadenoma, then the disease will be more florid, okay? It will not be mild disease. This kind of helps you also because, like, if it's pituitary tumor, usually it's mild disease. There is no rush to quickly diagnose the patient and treat the patient. Okay, you can take your time to work them out. Whereas like with ectopic ACTH, it is like, these patients are usually very ill, okay? If you don't diagnose them fast and you don't remove the tumor, they can just die on your hands, okay? With the severe complications of Cushing's, okay? And adenoma also to a certain extent. So you are a bit more pressurized to work up these patients if you suspect ectopic ACTH or adrenal origin tumors. But if it is good, you just suspect it is pituitary microadenoma, you can take your time. Okay. It's not that urgent. Okay. So ectopic ACTH, okay, the ACTH is markedly elevated. Okay, and you usually have florid severe disease, hyperpigmentation, and severe hypokalemia. And adrenal carcinoma to be high, meaning your testo and your DHEAS, and you might see hirsutism and virilization in a female. Okay. Now, so as I said, these two, adrenal lesions, whether they're benign or malignant, and ectopic ACTH, you need to quickly work up these patients, okay? Because the main complications we worry about will be severe sepsis. There's an increased risk of DVT. They may just die of PE. So you want to quickly do the test and then, start them on some kind of therapy which will lower the cortisol levels. You can use ketoconazole, metyrapone. These are some of the drugs that can medically lower the cortisol while waiting for surgery. You can't, because very often, like, it's difficult to arrange for urgent surgery. So as a bridging therapy, at least you quickly lower the cortisol so you can reduce the risk of sepsis, mortality, and uncontrolled diabetes, and PE as well. And while waiting for surgery, you need to be on DVT prophylaxis as well. Okay, so remember that. Okay, so screening for endogenous Cushing syndrome. Okay, first of all, you need to take a history, okay? Exclude exogenous glucocorticoid exposure. In our setting, it's often, traditional Chinese medicine or some kind of supplement they bought online, or ubat kampung or something like that. Okay? And then once you excluded exogenous glucocorticoid exposure, you can perform one of the following 3 screening tests, okay? You could choose just basal tests, okay, which would be your 24-hour urine cortisol, or your late night salivary cortisol, okay? Or you could do a dynamic test. A dynamic test in endocrinology means either a suppression test or stimulation test, okay? So if you just do a basal test, you're just measuring levels of a particular hormone, okay? Then you need 2 abnormal tests, okay? So urine and salivary cortisol, 1 abnormal result. Okay, so these are from the Endocrine Society testing guidelines, and they kind of go through in detail, like, the pros and cons of each test, etc. In some populations, okay, where you don't get enough information from just these tests, okay, you may want to do low dose dexamethasone suppression test, okay, where over 48 hours you give a total dose of 2 milligram of dexamethasone okay, which would be like 0.5 milligram every 6 hours for 48 hours, okay. So this test is more specific, and in some patients you might want to do that, okay. Yeah, basically, okay, so we do expect you to know how to interpret the results of the suppression tests, okay. So the overnight dexamethasone suppression test, okay, we do expect you to know how to do it as well, okay. This is the simplest test you can do as an outpatient, okay, and you don't have to perform 24-hour urine collection. Is quite cumbersome. However, the late night salivary cortisol is a very sensitive test, okay, but it's not available in most hospitals. I think some big hospitals have it, but UH we don't have it. I think I heard that Penang has it. I'm not sure, but certainly in private you have it, If you do want to, the patient can afford to, pay for it in Gribbles, it can be done. Okay, that is based on the, the physiology of diurnal secretion of cortisol. You expect cortisol to be lower at midnight and higher in the morning. Okay, so if your late night salivary is very high, that is very suspicious lah. Okay, so for overnight dexamethasone suppression test, you give 1 milligram of the oral dexa between 11 to 12 p.m. Next morning between 8 to 9 a.m. you measure the serum cortisol. In a normal person, it should suppress to less than 15 nanomole per liter. Okay, if it's higher than that, that is suggestive of endogenous Cushing's. Okay. If you do the 48-hour 2 milligram suppression test, also is 0.5 milligram dexa 6 hourly for 2 days. Okay, and on day 0 and day 1, and then the third day you measure the cortisol in the morning, serum cortisol. Again, it should be less than 50. So this is easy to remember: less than 50, less than 50, and there is a so these are the screening tests to establish that the patient has autonomous secretion of Cushing's. Now there is a third dexamethasone suppression test. That is to determine the subtype of Cushing's. We will talk about that later. So, okay, you do these tests, okay, and then you demonstrate that it is abnormal. There's either there are elevated urine cortisol levels or late night salivary cortisol, or it's non-suppressible serum cortisol after DEXA administration. Then the next step is to measure ACTH to determine is it ACTH dependent or ACTH independent. So ACTH independent should be less than 10. Okay, that is considered ACTH independent, and ACTH dependent would be more than 20. Okay, in these units, okay, maybe different units in other hospitals. The normal range which we use in our hospital, these are the units we use, the normal range is less than 51 lah. So if it is more than 20, so you notice that 20 is still within the normal range. Okay, so but it's the upper part of the normal range. Okay, so if it is more than 20, you need to, the next step would be to do an MRI of the pituitary gland. Okay, if it is less than 10, then the workup is very much simplified lah. You know for sure the origin is from the adrenal gland. You just proceed to CT of the adrenal gland, and then you proceed to adrenalectomy. The more complicated part would be ACTH dependent, because here you have to differentiate from ectopic ACTH. Okay, so next step is MRI pituitary. Okay, now when you do MRI pituitary, okay, remember I told you if it is pituitary Cushing's, tumor is often small. 50% of cases, okay, the MRI may even appear normal, the pituitary gland. Okay, the tumor is too small to pick up on MRI. So if there's no tumor, or the tumor is less, there is a tumor but it's less than 6 millimeters. So again, here you have the problem with incidentaloma, especially if it is an older patient. Okay, 10% of people, yeah, you know, if I scan them and they are older, they may have a bump in the pituitary gland, and you know, they are completely non-Cushingoid. Their cortisol levels are not elevated. Okay, so the worry is that when you have, even if you have a small lesion, it may be an incidentaloma. So you always have to confirm, is this lesion, so the same principle as the ABS lah, you need to confirm, okay, is this lesion actually secreting, high levels of ACTH. So for Cushing syndrome, we call it inferior petrosal sinus sampling, because it's the inferior petrosal sinus that drains the pituitary gland. However, if on MRI you have a large lesion, more than 6 millimeters, then you don't need to go through this step. Okay, then Cushing's disease is confirmed. You just send the patient for surgery and removal of the pituitary adenoma. So what is the principle of the IPSS? Okay, and how do you interpret that? So far, there have not been, I think, any past years where you have to interpret IPSS. But you know, you never know it's possible, so you just need to know the in future, so you just need to know the principles lah. So like personally, I feel that it's a bit unfair. Like to be honest, most of the tough questions tend to come from UKM endocrinologists, but just be prepared for it lah. Okay, I feel like this should be at the level of endocrinologists. You know, once you're an endocrine trainee, but they have very high standards in other centers. Okay, so same principle. Okay, the petrosal sinus drains the pituitary gland. Okay, so if you have a pituitary adenoma, okay, that is secreting ACTH, then the level of ACTH centrally should be much higher than the level of ACTH in a peripheral vein. So what they do in inferior petrosal sinus sampling, again, the patient is cannulated in the femoral vein. Again, it's not an easy procedure. Okay, there's quite a high failure rate if you don't send the patient to an experience center. So from all the way from femoral vein, they have to work the way, the catheter way up to the jugular vein and then into the inferior petrosal sinus, okay? And they take a sample, okay, from both the right and the left where they measure ACTH and then they compare it to peripheral ACTH, okay? Now, if the central to peripheral ratio is double, okay, 2 times higher centrally compared to peripheral, okay, then that is indicative that it's a tumor here, like the ACTH is coming from a tumor in the pituitary gland. But if it is less than 2, then it's most likely ectopic ACTH. Okay. Now with adrenal vein sampling, we use the cortisol to make sure the catheter is in situ. With inferior petrosal sinus sampling, we use prolactin. We simultaneously measure prolactin to make sure the catheter is in situ. Okay. Just know those principles, okay? So if your IPSS shows that the central to peripheral, CP stands for central to peripheral gradient is high, then it is pituitary adenoma, send the patient for surgery. But if it is less than 2, then you need to look for ectopic source. Then you need to scan the whole body, CT, neck, chest, abdomen, pelvis, or what would be more specific would be to do a nuclear scan known as a gallium dotatate PET CT scan. Okay, so this looks at whether these tumors express octreotide receptors. Okay, dotatate is octreotide receptor ligand. Okay, so it will bind to these tumors okay. So, okay, another old-fashioned test which may be useful to differentiate between ectopic ACTH and a pituitary adenoma is a test known as a high-dose DEXA suppression test. Okay, now high-dose DEXA suppression test. Okay, if you what you do is that you give the patient again over 48 hours. Okay. But instead of giving 0.5 milligrams 6 hourly, you give 2 milligrams 6 hourly. So, yeah, 2 milligrams 6 hourly. Okay. So, over 48 hours, it will be 16 milligrams. Okay. Now, with the high dose DEXA suppression test, you're trying to differentiate between ectopic ACTH and pituitary Cushing's. Okay, if it's Cushing's disease, okay, that's another thing you need to know. Okay, that when there is a pituitary adenoma that's secreting ACTH, we use the term Cushing's disease. Okay, whereas like any cause of elevated cortisol is known as Cushing's syndrome. Okay, so if it suppresses that with high dose, then it is pituitary. If there's no suppression, it is either ectopic or adrenal Cushing's, but you don't need to do this test for adrenal Cushing because the adrenal Cushing's the ACTH is low anyway. Okay, so okay, so this is how you do it. Okay, now those other 2 DEXA suppression tests, you don't need a baseline value, but for high dose DEXA suppression tests, you need to measure both the serum and the urine before you start the dexamethasone, and you also measure it after 48 hours. Okay, so in a normal person, after the giving high dose dexamethasone, the serum cortisol will suppress to less than 50%. You need the baseline, okay? And the 24-hour urine cortisol will suppress to less than 10% of baseline, which means it suppresses by 90%. Okay, so for serum, it's very low. In terms of like for the 0.5 milligram, overnight DEXA suppression test and the low dose DEXA suppression test, it should be less than 50 nanomole. For the high dose DEXA suppression test, it should be less than 50% for the serum cortisol. Everything is 50, okay? But the last one is percent, okay? So, okay. So, finally, we come to the third adrenal cause of hypertension. This is the rarest, pheochromocytoma or paraganglioma. Okay, it may be within the adrenal gland or maybe somewhere along the sympathetic chain. Okay, then it's called a paraganglioma. It's a catecholamine secreting neuroendocrine tumor. It's like even rarer than a zebra. It's a unicorn. Okay, and you get about 2 to 5 patients per million per year, and only accounts for about less than 1% of hypertensive patients, okay? But there are many genetic syndromes, okay? And more are being discovered, so make sure you're aware of those, okay? There's also this SDH syndrome, which is turning out to be one of the most common genetic causes of pheochromocytoma, okay? Of course, the famous adage is that it's a 10% tumor, that 10% are malignant, 10% are extra-adrenal, but it's not exactly 10% lah, okay? And they used to say 10% are familiar, but actually we're discovering more and more genetic mutations. Now we find that about 35%, almost 1/3, have some kind of germline mutation, okay? You see germline mutation, that means like it passes like, really from in kind of an autosomal dominant way lah, Extra-adrenal is not really 10%, can be up to 20%, okay? Malignant can be up to 15%, and about 15% can also be asymptomatic, and some have only paroxysmal hypertension, okay? So they may appear normotensive if you don't catch them during a crisis. Now, how do you investigate pheo? Biochemical confirmation before imaging, and the you need to you need to measure the metabolites, breakdown products of the catecholamines. So we measure urinary catecholamines and metanephrines and norepinephrines. You can either measure them in the urine or the serum, but more commonly we measure them in 24-hour urine samples. Now, the reason why the metanephrines, the breakdown products, are more sensitive than the actual catecholamine values is because like the catecholamines tend to be elevated only during a crisis or during a paroxysm. But because there is constant secretion and breakdown into metabolites in the tumor, and which is released into the bloodstream, whether you're having a paroxysm or not having a paroxysm, the metanephrines and norepinephrines are more sensitive. They're continuously secreted. Therefore, they have a higher diagnostic accuracy. Okay, so we don't, if you have given an option for VMA measurement, which is highly affected by food, whereas the catecholamines and norepinephrines are not, okay, you shouldn't choose that as a screening test for pheochromocytoma. That's a very old-fashioned test, which, like, many hospitals no longer do because there are many, dietary items such as banana, vanilla, etc., interfere with that test, okay? Now, there are some confounders even to the catecholamines and metanephrines. Obviously, if you have a drug that is a sympathomimetic, is a sympathomimetic, that is going to cross-react. So those things are very obvious. So, for example, pseudoephedrine, phenylephrine, these nasal decongestants, they are similar in structure to catecholamines. They're going to confound it, okay? And say Parkinson's disease, levodopa, carbidopa, is similar to dopamine, okay? So of course, it's going to be measured, okay? But even drugs like tricyclic and antidepressants, even labetalol, depending on how, what method you use to assay, and even calcium channel blockers also can confound it, okay? The most accurate way of measuring the urine catecholamines and the serum catecholamines is something we call LCMS, okay? Liquid chromatography mass spectroscopy. So that method has like less drugs, that less confounders, but there are still some confounders lah. And no matter what method you use, of course, it is under physiology, immediately post-seizure or something like that, the catecholamines are going to be high lah. Okay, if there's some acute intercurrent illness or surgical stressor, it may be for a false positive lah. So you need to repeat it under non hospitalization situation is still high, then it is more significant. Okay, so a positive result would be, because there are all these confounders like physiological stress can also elevate it, OSA can also elevate it. So then there must be a higher threshold for positivity. So if your 24-hour urine CATs and METs are more than 2 times upper limit normal, then we usually take it seriously okay, or elevated plasma fractionated methamphetamine. Okay, so this we don't really, not many centers do the plasma methamphetamine. Usually we have to outsource it to people. So more commonly we do the urine test. Okay, so we have to discontinue any drugs that can interfere. Okay, there's a whole list of things. If you're doing HPLC method of measurement, labetalol also has to be discontinued. But even LCMS does have some confounders. Okay, so of course, like again, if LCMS, strangely enough, LCMS paracetamol also can affect it. Okay, so once you have confirmed, again, biochemistry before imaging. Okay, so once you have confirmed that it's high, then you do a CT scan. Now again, there's a very classic CT imaging phenotype. Okay, data interpretation, you may be given CT scans, and you must be able to like decide, is this Con syndrome, or is the tumor more likely to be pheochromocytoma just based on the imaging. So I told you with Con's adenoma, classically it's a hypodense lesion. Okay, whereas pheochromocytoma classically is a hyperdense lesion, high Hounsfield units, more than 10 units on the uncontrasted view. And usually if you compare it on the uncontrasted view to the liver, it'll be more hyperdense than the liver. Okay, so if you also have a large lesion, it is cystic with hemorrhagic changes, it takes up a lot of contrast and it retains the contrast. Okay, so the absolute and relative washout will be low. It will be retaining the contrast. Okay, then that is more suggestive of pheochromocytoma. Okay, so sometimes that's a simple CT scan, contrasted CT scan. But sometimes if you might need to resort to functional scans, MIBG scan or rotated PET CT or FDG PET. Okay, so this is a classic picture of a pheochromocytoma. You can see it's a very large adrenal tumor above the right kidney. It is like heterogeneous. There's necrotic areas which are hypodense, and there are other areas which are hyperdense, and it takes up a lot of contrast. Okay, so this is the classic pheochromocytoma, very different from your Con's adenoma. Okay, you need to know about perioperative management of somebody with pheochromocytoma, how to prepare them. Okay, and also during a crisis, how you're going to manage pheochromocytoma crisis. The key principle we like to test you on is that you need to know that in patients with pheochromocytoma, you must never give a patient beta blockers without the patient first being on alpha blockers. And the reason for this is because if you give a patient beta blockers first without the patient being on alpha blocker, all the beta receptors will be blocked, and then all the catecholamines will rush to bind to the alpha receptors, and that will cause massive vasoconstriction and elevation of the blood pressure. So first you need to start alpha blockade, then a couple of days later you introduce beta blockade. Okay, and classically the best agent would be when you're preparing a patient for surgery would be to use a non-selective long-acting irreversible alpha blocker, where a drug that binds to the alpha receptor, and then when there's like a surge of catecholamines secreted, it cannot be displaced from the receptor, okay, because it is irreversibly bound. Okay, so phenoxybenzamin is such a drug, whereas if like you give and prazosin is reversible, but it's way too short acting. There are longer acting alpha-1 blockers such as terazosin and doxazosin, which are better than prazosin, but still it's not as good as phenoxybenzamine because it still can be displaced from the receptor. Okay, so you need to prepare the patients. They need to be on alpha blockade for 7 to 14 days pre-op, and 2 to 3 days after initiating the alpha blockade, you add the beta blockers. Okay. Some centers, they do like to use this. Okay. Labetalol is another agent with both combined alpha and beta blockade, but the majority is beta blockade. Okay. 7 fold higher beta blockade compared to alpha blockade. Okay. So it's not a very good alpha blocker. Okay. And some centers even use calcium channel blockers. Okay. And of course, because these patients are chronically volume contracted because they are vasoconstricted, therefore they also have postural hypotension. So when you're preparing them for surgery, you need volume replacement with normal saline. The other important thing is to avoid precipitants of crisis and catecholamine release. That will be arterial contrast. So like, say like you have someone with pheochromocytoma, but you didn't realize that they have pheochromocytoma, and then they go for coronary angiogram, then that can also precipitate a crisis. And these are the other drugs that can precipitate a crisis, which I previously mentioned. Okay. So, okay, so we will end here. Are there any questions? Okay, so since you have the recording, you have the slides, right? Any questions?
Hi, Prof. Prof Kosh here. I have a question.
Hi. Kosh. Kosh, why are you still here?
Usually, I just want to learn.
You're very keen.
Prof, usually
Oh,
the
okay,
commonest
very good.
case in our HKL MOPD clinic, we always see they refer for young hypertension, where the BP is about
Kosh, you are in
100.
HKL, is it?
Yeah, Prof.
Okay. Okay.
So we always get like 30
Yeah.
years old, 28 years old. BP is about 150 with single antihypertensive, but the potassium will be very low. So if let's say we want to subject this patient to ARR, but most of the time, even on 2.4 gram of TDS, we can't achieve the potassium of 4. So how much maximum we can give, Prof?
The patient is compliant, and sometimes but it's still interpretable. Okay, so if you go back to that table also, just like with certain drugs you can interpret, we know that hypokalemia will lower the aldosterone. So if the aldosterone is still very high, even though the potassium is low, definitely it is primary hyperaldosteronism, false negative. So if the potassium, you somehow like you tried your best as outpatient to raise the potassium but couldn't, but you did the ARR and the aldo is still very high, you refer to an endocrinologist. It's very likely it is hyperaldosteronism. But if the aldo is low, then it can give you a false negative hypokalemia.
Okay, Prof. Thanks, Prof.
Is that okay, Kosh?
Yeah, Prof. Can. I'm just afraid of sending them, then getting false negative.
There's some very refractory. The false negative is an issue, but if it's positive, it's positive. Okay, so maybe we can quickly do some questions, just like some quick, simple questions. I think it may be even too simple, but never mind. I think I need to. I think I need to stop share first. And let me try new share first. No, I think it's not a good idea to do on this. Sorry, guys. I think it's a good idea to do. I guess it's. We'll just do 1 or 2 lakhs. So can you see my slide? The new share, a question?
No, Prof.
Okay, now Kosh, can you see? No, I think I need to. Now can.
Can, Prof.
Okay. So Can, okay. So, this, maybe we'll just do one lah. 35-year-old man presents with throbbing headache, palpitations, shortness of breath, and profuse sweating for 2 months. BP was 220 or 130, pulse rate 130, respiratory rate 22, temperature is 37.8. And cardiovascular examination reveals a gallop rhythm with no murmur. There's bilateral papilledema with silver wiring on fundoscopy, and examination of other systems was unremarkable. ECG shows LVH and T inversion in leads 2, 3, and AVF. These are his initial investigations. So let's see. Okay, so these are the questions. So what is the diagnosis? So anybody want to volunteer? Peanut? Peanut, what's the
Yep.
diagnosis? Yeah.
Pure.
So you take, but is that answer complete? Okay, we'll see what the actual answer the examiners gave. But like, if you just say Pheo, is it complete? So this is an important principle when you answer the questions lah. Yeah. What's that?
Pheochromocytoma crisis.
Yeah, okay. So probably, yeah, something like pheochromocytoma crisis or hypertensive emergency secondary to pheochromocytoma or something like that. But let's see whether that's what they wanted lah. Sometimes they can be very fussy to get the full marks. So the way we mark will be like, if just like pheochromocytoma, then it's just like 1 mark. But maybe like if you said hypertensive emergency, another half mark or something like that lah. Okay. So list 2 immediate pharmacological options for management of this patient. Would anybody want to volunteer? Let's go back to the presentation and let's see. Okay, yeah. So how would you manage the blood pressure? Just now Boon asked me a question. Boon, can you help?
Like ED.
IVI labetalol.
Okay, yes, good. IVI labetalol. Anything else? I guess the hypokalemia as well needs to be corrected. But as an antihypertensive agent, anything else besides the IVI labetalol? Anybody? So hypertensive emergency, how do you treat?
Nitrates, Prof.
What's that called?
Nitrate?
What is it? Nitrate, is it? Did you say?
Yeah.
Nitrate, okay. So nitrate, I will accept nitrate infusion. I will accept in this situation because there is a gallop rhythm lah. Nitrate is most useful when there is heart failure, but otherwise it's not a very powerful agent for lowering blood pressure in a hypertensive emergency. The other agents you could use, like, although we don't often use it lah, but you need to know, nitroprusside infusion, although it would be ICU setting. Nitrate, I agree, is easier to use, but usually it's best in patients who have some element of heart failure. hydralazine infusion is something else that you could use during an emergency. Maybe yeah, that would be like, because at this stage you do not yet know. You think most likely it is pheochromocytoma, but there are other differential diagnoses also. So like what would the other differential diagnosis for the underlying disease be? Any more information given? No, no other information given.
Cushing's.
Cushing's, okay. What else? Primary
Primary
hyperaldosteronism is also possible lah. Rarely, occasionally we do see people presenting with hypertensive emergency. Although more commonly, it's not so common lah. It's usually Pheo that has the most marked elevation in blood pressure. And then list 3 life-threatening complications of the above, Trinette. Meaning the high blood pressure lah. 3 life-threatening.
IC bleed, intracranial bleed.
Okay, intracranial bleed. Okay. What else?
Stroke.
Sorry, what's that?
CBA, stroke, bro.
Yeah. Okay, so you think more of intracranial bleed, but you also possibly could get a large ischemic stroke. It's more of intracranial bleed lah. What else? Heart failure lah. Heart failure and acute renal impairment. Is there anything else? Okay, let's see what they wanted. Okay, so hypertensive emergency. Okay, they wanted more of hypertensive emergency initially, and then later they wanted all this lah. And which I really like. I disagree with this answer which they gave, hyperthyroidism. If you meet me in the exam, please never give me this. Like, have you ever seen somebody with hyperthyroidism present with a hypertensive emergency? Like, it's like, crazy. Okay, they also drug cause, ecstasy, cocaine, they accepted. Withdrawal, default of antihypertensive, also they did mention that. For some reason, they don't list Cushing's, but I would include that. I'm just giving you the answers that, were listed. But sometimes, like, when we are marking papers that, somebody will come up with this plausible, amongst the examiners, say like, you should consider this, we will consider that lah. Okay. So I told you IVI labetalol nitrate is a possibility because he has some gallop rhythm, nitroprusside, hydralazine, nicardipine, but it must be IVR, they say, so all these details matter. Okay. So ICB, APO, AKI, aortic dissection, we missed that out. Okay, so this is an example of a question. Actually, I shouldn't be giving these past year questions in this format because you all can take and keep it. Okay, I will end over here. Okay, okay, guys. Any questions you want to ask me? Okay, any questions? Okay. Okay, guys. Thanks. Yeah, it's